Welcome you to our grand, Pleasure to welcome you to our grand rounds on Monday, November 9th here at Mount Sinai. It is my privilege to introduce our visiting professor digitally, Dr. Philippe Pibarot. Dr. Pibarot attained a doctorate in veterinary medicine in 1987 at the University of Claude Bernard in Lyon, France, with a PhD in biomedical sciences from the University of Montreal in April of 1995. He is a professor at the Department of Medicine at Laval University and holds the Canada Research Chair in Valvular Heart Disease at the Quebec Heart and Lung Institute. The objective of his research program is to develop and validate novel approaches to improve the diagnosis, prevention, and treatment of valvular heart disease. He is currently the principal investigator of 3 multi-center studies funded by Canadian Institutes of Health Research and the Heart and Stroke Foundation of Quebec. He has published more than 300 articles and presented 290 invited conferences in the course of his career. He is associate editor for the Journal of American Society of Echocardiography. He received the Annual Achievement Award of the Canadian Society of Echocardiography in 2010, the Research Achievement Award, Canadian Cardiovascular Society, and the Feigenbaum Lecture Award, American Society of Echocardiography Award in 2012. It is without further ado that I introduce our visiting professor today, Dr. Pibarot.
Well, thank you very much. It's a great pleasure and privilege for me to be with you today, at least virtually. Well, I have many great friends and collaborators at Mount Sinai Medical Center, and it's good to meet all of you. I should say that the work that is done at your center, at your institute, has been a great source of inspiration for us in our field, in the field of valvular disease. Your center is really a leading center in the field. So thank you so much for all this contribution and for inspiring us in our work. So today we're going to talk about hot topics and controversies, because hot topics are often controversial in the field of aortic stenosis. I do have some disclosure before getting started. The most important is that we are the echocardiographic collab for several major trials in the field of transcatheter aortic valve replacement, including Partner 3, TAVR, and early TAVR in particular. So the burden of aortic stenosis is huge. This disease afflicts about 1 million people in North America only. There is no pharmacotherapy. No drug is able to slow or halt the progression of aortic stenosis. So when the patient gets to have a symptomatic severe AS, the only option is to perform an aortic valve replacement. For many years, it has been only surgical. Now we have the transcatheter aortic valve replacement. So this disease is directly responsible for about 20,000 deaths and 80,000 aortic valve replacement per year in North America only. So the estimated cost for one procedure from one valve replacement is between $50,000 and $90,000. So you appreciate the huge socioeconomic and healthcare burden associated with aortic stenosis. So the first hot topic of controversy I would like to address with you is the timing of intervention in asymptomatic severe AS. I mean, we know that timing is everything. Timing is everything in politics. We know that very well with this election. Timing has been very long and stressful. But in the field of AS, in the management of aortic stenosis, timing is key as well. So when to intervene in aortic valve disease? Well, when you have mild, moderate AS, of course, you only follow the patient. When you are at the stage of a severe AS, but the patient has no symptoms, no LV dysfunction, this is where there is a controversy. Should we do an earlier intervention, early AVR, or watchful waiting or surveillance of the patient? And now you have the patient with severe AS, no symptoms, who nevertheless have LV dysfunction, which is defined in the guidelines as an LV ejection fraction lower than 50%. Not many of these patients, but still it is important to identify them. And for these patients, there is a class 1 indication for aortic valve replacement now, as well as in all the patients with severe AS who have symptoms. I would like to start with a case. I have actually 4 cases to illustrate the 4 hot topics that we're going to discuss today. So this is a 80-year-old man with severe AS, asymptomatic. So this is what they call C1 stage in the American guidelines. There is no evidence of particular cardiovascular risk factor, no evidence of coronary artery disease. LV ejection fraction is preserved, no dysfunction. The stroke volume is 85 ml, which index for body surface area is 42. So this is normal LV outflow. And AS severity on echo, well, the valve is, as you see, thickened and calcified, restricted opening. The peak jet velocity is 4.25 meters per second with a mean gradient of 46. The valve area by continuity equation is 0.89, index 0.44. So by all means, this is an hemodynamically severe aortic stenosis. There is no doubt about this. The patient has no symptoms, which actually has been confirmed by exercise testing, because this is, of course, another issue, is to be sure that the patient is true asymptomatic. So this patient did a good test, has no history of symptoms. So the dilemma in this type of patient is with true asymptomatic severe AS is, should we do an early, let's say, prophylactic aortic valve replacement, or more watchful waiting strategy? And well, this is a, I don't like to call it a meta-analysis. It's more a pooled analysis, because at the time there were only 4 studies when we did this analysis with Philippe Généreux from Morristown. We found that if you look at the studies that compared early AVR versus watchful waiting asymptomatic severe AS, there seems to be a superiority of an earlier intervention in terms of all-cause mortality and cardiovascular mortality. Having said that, all these studies were non-randomized, so this is to be taken with a grain of salt. And if you look in the guidelines, the European guidelines or the American guidelines, actually there is no class 1 indication of AVR in these patients with asymptomatic severe. But you nonetheless have 2A indication. So there are some opening. So 2A indication, if the patient has a very severe AS, so which is defined somewhat differently in the European versus American guidelines. It's a peak jet velocity more than 5.5 in the European guidelines, 5 meters per second in the American guidelines. So very severe AS, or a fast progression of the stenosis, which is defined as a progression rate of the peak velocity of 0.3 meters per second or more. And in the European guidelines, there are other criteria, such as a severe valve calcification, a markedly elevated BNP, which is 3-fold versus normal range, and a decrease in blood pressure during exercise and pulmonary hypertension. So, well, the patient I showed you today has none of these risk markers, so has no evidence of 2A indication of AVR according to guidelines. So there are also some randomized studies, very few actually, essentially one, which is the one from the recovery trial, a South Korean trial published last year in New England Journal of Medicine. This trial was, however, focused on patients with very severe AS. Okay, it's not all comer with severe AS and no symptoms. It's patients with very severe AS, so peak jet velocity at baseline more than 5 meters per second. And for this patient, we already have some opening in the guidelines. There is already a 2A indication. So it's more corroboratory, if you will, than really addressing the issue of timing in asymptomatic CVAs. But it's a small trial, about 70 patients in each arm. But I mean, it's a first step. It's a first proof of concept showing that patients having earlier surgery actually have a lower rate of mortality from all cause, as well as from cardiovascular mortality, compared to patients with conservative care, so more watchful waiting strategy. So there are several ongoing trials now assessing the timing of intervention. So it's really a strategy trial. So for example, the early TAVR trial, where patients with asymptomatic severe AS who are older than 65 years old and who are at low surgical risk, actually these patients undergo a treadmill press test to confirm that the patient are true asymptomatic, and if yes, they are randomized to a transfemoral TAVR versus a clinical surveillance. So a clinical surveillance until they develop symptoms or LV dysfunction, and in such case, they would undergo a TAVR. So we are really, as opposed to the previous partner trials where we're comparing two different strategies of AVR, TAVR versus SAVR, in high risk, intermediate risk, and low surgical risk, recently with a partner 3 trial. Here, we're really comparing more the timing of intervention in this patient with asymptomatic CVAS, such as the patient I presented in the beginning. What I can say is we don't know yet the result of the early TAVR trial. And we won't know before several years. But we can already say that whatever are the results, positive or negative of the trial, it's not all patients who will have the same benefit of an earlier intervention or watchful waiting. So we already know that early AVR is not for all patients with asymptomatic CVAS, and vice versa. Watchful waiting is probably not the good strategy for all patients. So we need to individualize the timing of intervention and also the type of intervention depending on the baseline characteristic of the patient. And in this regard, I would like to address an important concept here, which is the concept of staging cardiac damage in patients with AS. And really, I think our assessment of patients with AS needs to be twofold. We need to grade the severity of aortic stenosis, mild, moderate, severe. But then the second component of the assessment is to assess the extent of cardiac damage caused or associated with aortic stenosis using a scheme that I will show. So, and this is here where we do the parallel between oncology and cardiology. In oncology, they have this twofold assessment with a grading of the tumor and then a staging of the tumor. And it's only with this twofold assessment that they can optimally guide the treatment of the patient. Well, we should do the same in cardiology and in AS. Yes, we need to continue to grade the severity of aortic stenosis, but we also need to do a better job at staging the extent of cardiac damage. And this is what we proposed with Philippe Généreux a few years ago. We proposed a simple scheme to stage the extent of cardiac damage in patients with aortic stenosis. So it's a stage 0, 1, 2, 3, 4. Stage 0 means there is no cardiac damage associated with aortic stenosis. Stage 1 is damage at the left ventricle level, which is the cardiac chamber that is immediately upstream of the disease of the aortic stenosis, right? And so if you have LV hypertrophy defined using this the LV mass index more than 115 in men and 95 in women, well, you qualify for stage 1. Also, other criteria are the E/V prime ratio more than 14, which is a marker for LV diastolic dysfunction, and of course, LV ejection fraction less than 50%, a marker for LV systolic dysfunction. So if you have any of these 3 criteria, you're stage 1. You don't need all 3, okay? And stage 2, well, we go upstream. It's left atrial / mitral valve damage with dilated left atrium, moderate CVMR, and or atrial fibrillation. Stage 3, pulmonary arterial tricuspid valve damage with systolic pulmonary hypertension with a cutoff of 60, and or moderate severe TR. And finally, stage 4 is right ventricular damage, which is moderate, the presence of moderate or severe RV dysfunction, because we know that whatever the cardiovascular condition, when you start having a failure of the right ventricle, it's not a good sign, and it's associated generally with poor prognosis. So you see, these are echo parameters that we measure every day in the routine echo in a patient with AS, with criteria and threshold that are, you know, the one that we have in the guidelines and recommendation of the American Society of Echo, etc. So what we did, we applied the simple staging scheme to the partner 2A trial. So the partner 2A, again, is patients with intermediate surgical risk randomized to TAVR versus SAVR. We pulled together the two arms, TAVR and SAVR. We assessed the extent of cardiac damage with the echo that was obtained prior to AVR, and we looked how this staging established prior to intervention predicts mortality after AVR, and the results were striking. You see that the staging had a very powerful prognostic value, and for each increase in one stage, well, mortality was approximately double. And this is very discriminative, as you see. So this was, of course, very interesting result and a very good proof of concept. And this is useful for risk stratification prior to AVR. It doesn't necessarily change the way you're going to treat the patient because all these patients already had an indication for intervention. So of course, the next step was to adapt and apply this staging scheme to a patient with asymptomatic CVAS, such as the patient we discussed at the beginning of the presentation. We did some adjustment here compared to the original classification that we proposed with Philippe. So this paper was published in JACC in 2019 with my PhD student, Lionel Tastet, being the first author. And you see what we did, stage one, we did some modification. Criteria for LV hypertrophy remained the same. For diastolic dysfunction, we used more a multi-parameter integrative approach, and as recommended by the American Society of Echo guidelines. And we had as a criteria a grade 2 or more diastolic dysfunction, so moderate or severe. LV ejection fraction, importantly, in these patients with asymptomatic CVAS who all had preserved LV ejection fraction at baseline, we raised the cutoff for LV systolic dysfunction from 50 to 60%. So we use an LV ejection fraction of 60%. And why did we change the or increase the LVF cutoff? Well, there are several studies, including some important studies published in JACC, showing that patients with LV ejection fraction between 50 and 60% with aortic stenosis very often have subclinical systolic dysfunction. Because we have to keep in mind that the LV ejection fraction underestimate the extent of systolic dysfunction, particularly in patients with aortic stenosis, because they have LV concentric hypertrophy. So it makes a lot of sense to use a maybe higher threshold to identify, to increase the sensitivity of LV ejection fraction to detect this patient with subclinical dysfunction. And I hope that in the future, in the guidelines, they will eventually propose to raise this cutoff that is in the guidelines to define LV systolic dysfunction and trigger intervention from 50 to 60%. We'll see. Another criteria that we included in the stage 1 to identify subclinical LV dysfunction is global large north strain that we can measure nowadays easily with a spectral tracking imaging. And so when there was a GLS less than 15%, this was a criteria for stage 1. So again, if you have one of these 4 criteria, the patient qualifies for stage 1. Stage 2 basically remain the same, stage 3 as well. Stage 4, what we also included, we included more precise criteria to define moderate RV dysfunction, but also we included a marker for low flow state with a stroke volume index lower than 30 ml per meter square, which is actually moderate or severe low flow state, because low flow is I think the first step of cardiac decompensation of heart failure, even if the patient has no symptoms. So this is an important overall marker of the pump function of the heart. And we included in stage 4 because the cause of this low flow state can come from the left ventricle, but it can also be due to MR, to RV dysfunction or TR. So we applied this staging scheme to patients with asymptomatic aortic stenosis. So this was a multi-center study with patients followed in heart valve clinics in different centers in North America and Europe. And actually, again, the results were quite striking, because here we had really a cohort of patients were well followed, carefully followed, were all true asymptomatic when there was some equivocal history about the symptoms, then an exercise test was performed. So in these patients with asymptomatic severe AS, actually 61% were in stage 2 or more, 2, 3, 4. So meaning that even if they had no symptoms, well, the majority of these patients had advanced cardiac damage. And when the stage was 2 or more, there was an increase in the risk of death, and in the relatively short term. You see on these Kaplan-Meier curves, the blue curve is stage 0, yellow or orange is stage 1. So stage 1 is, pretty much the same, at least for the first year, versus stage 0, and then the curves start to separate. But at least in the short term, stage 1 has a relatively good prognosis. But then the stage 2, which is the red curve, we start to see some increase in the risk of mortality, even within the first year. And stage 3, 4, that was pulled together, that's the black curve, the same, So I think important take-home message here, I think we have to move away from symptoms in aortic stenosis and rely more on more objective markers, such as, echo parameters, to assess the extent of cardiac damage. I have some red lines that appears on my screen, but hopefully you don't see them, but it's not a big problem. So yeah, so actually what the take-home message again is, of course, if you have symptoms, that's a no-brainer. Symptoms, CVS, we need to intervene now. But where we have to be very careful is when there is no symptoms. Absence of symptoms does not necessarily mean that there is no cardiac damage and that the patient is not in the first phase of cardiac decompensation and heart failure, and that we should not intervene. So this is, I think, how useful and could be this cardiac damage staging and how it can be applied. So again, there are several criteria that we proposed, simple criteria based on echo parameters and criteria that we use every day. Of course, this criteria and definition of stage is a work in progress, and we can further enhance this algorithm by adding other markers, markers beyond the echocardiographic parameters, such as blood biomarkers, BNP, troponin, high sensitivity troponin could be very interesting to implement. Also, extracellular volume, so the extent of myocardial fibrosis measured by cardiac magnetic resonance imaging may in the future be included in this staging, and others eventually. And if for patients with asymptomatic severe AS, the patient is in stage 0 or 1, I think it is reasonable to carefully follow the patient, so echo clinical surveillance, and not intervene now. But if the extent of cardiac damage is more advanced, so stage 2 or more, then I think this is an argument for intervening earlier. And then in patients with symptomatic severe AS, here the challenge is not to determine if we need to intervene. We need to do AVR. Now the challenge is more to select between TAVR versus SAVR, and here again, I think the assessment of the cardiac damage by this staging scheme may be useful. And if the staging is 0, 1, 2, it is probably reasonable to do a SAVR or TAVR. But if stage 3 or 4, then there are some recent publications suggesting that TAVR, especially a transfemoral TAVR, may be superior to SAVR in these patients who are the impact at the level of the right side unit, so who are in stage 3 or 4. So if we come back to the case, well, this patient actually has criteria for LV hypertrophy. He also has, by speckle tracking, a global notional strain of -14%. So he has actually 2 criteria for stage 1, but no further criteria for stage 2, 3, or 4. So again, true asymptomatic patient with severe AS, so grading is severe grading, staging is 1. So it would be reasonable in this patient to wait, and doesn't mean that we should not do nothing. We need a careful clinical and echo follow-up every 6 months, and to eventually intervene later. So the second topic and controversy is, and here we go to the other extreme of the spectrum. So we just talked about patients with severe AS and no symptoms, and now we're addressing the issue of patients with moderate AS and heart failure symptoms, systolic heart failure. And the question is, would AVR be beneficial in these patients with moderate AS? I'm talking about, eventually considering an aortic valve replacement in patients with moderate AS. And as you know, there is absolutely no indication for intervention in patients with moderate AS at the present time in the guidelines, unless they undergo another cardiac surgery. So the outcome of patients with moderate AS is not that good, actually. If you look at this very large study from Australia, from the National Echo database, well, you see some increase in risk with mild AS versus no AS. So this is actually what you have here is the all-cause mortality at 1 year in black, and the blue box are mortality at 5 years. So you see some increase in 1 year and 5 year mortality with mild AS, but with moderate AS, there is another big step. And actually moderate AS, the increased risk of mortality is almost as bad as severe AS. So these patients with moderate AS definitely not have a good outcome. And this brings me to the second case. This is a patient with, as we'll see, with moderate AS, low EF, and heart failure symptoms. So this patient at rest had a very poor LV ejection fraction of about 20%. Low flow state, the stroke volume was only 36 ml, and mean flow rate, which is the stroke volume divided by the LV ejection time, also very low. If we look at the severity of the aortic stenosis by echo, well, you see a mean gradient of 22. And a valve area of 0.85. So this is typically, what we call a discordant grading, because the valve area is severe, but the mean gradient is not severe. So here we don't know really what is the true severity of the stenosis. And generally, what we do in this type of patient is a dobutamine stress echo, a low dose dobutamine stress echo up to 20 mic. And here with dobutamine, the patient has a good response. LVF improved to 30%, stroke volume increased to 55 ml. So there is contractile reserve, there is flow reserve in this patient. And with this increase in flow, what we see is some good increase in gradient, from 22 to 32. But at the end of the dobutamine, the gradient is still non-severe, it is still moderate, okay? 32 is below 40. The valve area on the other end went from 0.85, so severe, to 1.2, so non-severe, so moderate. So with dobutamine stress echo, we actually reconciled the discordant grading, and now both the gradient and the valve area tells you that the stenosis is not severe, that the stenosis is what we call pseudo-severe. And in fact, pseudo-severe doesn't mean that there is no stenosis or mild stenosis. This is still here a good moderate aortic stenosis. And the question is then, okay, this is moderate aortic stenosis, this is not severe stenosis, so there is no indication for valve replacement. But is this moderate stenosis really benign for this depressed ventricle with an LVF of 20%? Well, the answer is no. This is a multi-center study that we did some years ago. It's a retrospective study of patients with moderate AS, eventually confirmed by the dobutamine stress echo, with depressed LV ejection fraction, LVF less than 50%. And the outcome was not good. At 4 years, 61% of them had either died, required aortic valve replacement, or underwent heart failure hospitalization. And I think one important message today, again, is that what is moderate AS for a good ventricle may actually be severe for a depressed ventricle. It's always a question of balance between the magnitude of the hemodynamic of the pressure overload imposed by the stenosis versus what the ventricle is able to handle. So a moderate AS, a mean gradient of 20, 30, 35 is okay for a patient with preserved with a good LV systolic function and LVF of 65%. But the same moderate AS for a patient with a depressed ventricle, a patient with systolic heart failure, might actually be detrimental and as bad as a severe stenosis. So this is what led us to propose this trial. This is the TAVR Arnold trial. Well, this is a provocative trial. This is a 300-patient trial where patients with moderate AS confirmed by resting double-time stress echo and optimized heart failure therapy. So that's patients with moderate AS, systolic heart failure. The medical therapy has been optimized, including resynchronization. These patients are randomized to TAVR. So to unload this moderate AS versus medical therapy. And the endpoint is actually, the primary endpoint is a hierarchical occurrence of all-cause mortality, disabling stroke, hospitalization for heart failure or aortic valve disease, and change in KCCQ. And I think the rationale here is that we know very well that one of the key point of the treatment of patients with systolic heart failure is to reduce the afterload. The problem in these patients with moderate AS is that a large part of the afterload is fixed because it is caused by the stenosis. So we cannot change the moderate AS by pharmacotherapy. We cannot reduce this part of the afterload. So this is why we believe that a TAVR in this patient with moderate AS and systolic heart failure may be beneficial. So this trial is ongoing. We'll have to see what are the results. So this summarized here, again, this twofold assessment of aortic stenosis with in the column, in the left column, the grading of AS severity where, well, first aortic sclerosis, mild AS, grade 2 would be moderate AS, grade 3 would be severe AS, but no symptoms, asymptomatic, and grade 4 would be the symptomatic severe AS. And then you have on the top line the staging of cardiac damage, stage 1, 2, 3, 4. For patients who were in grade 4, so symptomatic severe AS, we already have indication class 1 or 2A for intervention, so that's okay. For those with grade 3, so the asymptomatic severe AS, again, such as the patient we discussed initially, well, there are some opening in the guidelines, but it's only the 2A, and there are several trials ongoing, including early TAVR, evolved, EasyAS. So we'll have to stay tuned. And then for the grade 2, so the moderate AS, but with advanced cardiac damage staging, we have, as we just discussed, the TAVR Unload trial. So the third controversy I would like to, a hot topic that I would like to address is the management of low gradient AS. Why? Because low gradient AS is one of the most challenging entity to diagnose and manage and treat in AS. So low gradient AS is defined as a valve area that is less than 1 centimeter square, so severe, but with a mean gradient that is lower than 40 millimeters of mercury and peak jet velocity that is less than 4 meters per second, so non-severe. So that's why we say there is a discordant grading, and so the stenosis severity is uncertain here. And there are actually 3 subtypes of low gradient AS. You have patients with low LVF and low flow. That's what we call the classical low flow, low gradient. It is labeled as D2 stage in the guidelines, in the American guidelines. And then you have those with preserved DF. They have preserved DF, but still they are in low flow state, which is defined in the guidelines as a stroke volume index lower than 35 ml per meter square. And this is what we call, and what we described for the first time in 2007 as paradoxical low flow, low gradient, a D3 stage in the guidelines now. And then there are the patients with preserved DF, normal flow according to stroke volume index, but still they have this valve area gradient discordance, and we call them normal flow low gradient AS. And as of now, they are not really well addressed in the guidelines. Maybe next edition we'll see. So this is the third case, a patient with paradoxical low flow, low gradient, so the second type, 82-year-old woman. She has hypertension, history of hypertension, well controlled with ACE inhibitor. No evidence of CAD. She is in functional class 3, has been recently hospitalized. LVF is 65% by biplane symptom, and you can appreciate that, there is no evidence of alveolar dysfunction based on LVF. But if you look at global longitudinal strain, that's a different story. She's a minus 13%. So she has some impairment of longitudinal systolic function. She has grade 2 diastolic dysfunction with increased filling pressures. The ovary prime ratio is increased. Here, severity on echo, you see a severely calcified valve on this parasternal long axis U, 2D and 3D. Thickened valve, calcified, definitely. The valve area is 0.64, index 0.36, so all severe. The Doppler velocity index, which is the ratio of the velocity time integral, is also severe. But the mean gradient is not that impressive, 26. And actually is in discordance with the valve area and Doppler velocity index. And the reason for this discordance might well be the presence of a low flow state, because you see the stroke volume index is 29 ml per meter square, which is lower than 35. So this might be the reason for the discordant gradient. And in fact, paradoxical low flow, low gradient, I like to say that this is in fact the HREF form of AS. Classical low flow, low gradient with the low EF is the HREF form. This one, sorry, is the HPEF form of AS. So paradoxical low flow is the heart failure with preserved LV ejection fraction. And you see many of the features here of HPEF, more often seen in women, elderly women with concomitant history of hypertension, this small ventricle with pronounced concentric remodeling. And when you think of it, these patients with this small, thick ventricle with impaired filling, impaired longitudinal strain, even if the LV ejection fraction is preserved, cannot generate a normal stroke volume. So the low flow state is easy to explain here. So what should we do in this patient? Well, in classical low flow, low gradient with low EF, we would do a dobutamine stress echo, as we did for the patient with moderate AS and systolic heart failure. But here, dobutamine stress echo in HPEF in this patient with paradoxical low flow, low gradient with this small ventricle with pronounced concentric remodeling and preserved LVEF is probably not the optimal test. So what generally we prefer to do is a non-contrast CT. So very simple and fast imaging test to do. So again, it's a non-contrast, and it is very useful to differentiate a true versus a pseudo-severe AS in low flow, low gradient AS, in all forms of low gradient AS actually. You see an example here of pseudo-severe AS, and on the right, an example of true severe AS with, of course, very different aortic valve calcium score. So the aortic valve calcium score is measured on a non-contrast CT using the modified Agatston method. And the important caveat, however, is what we need to use different cut point in men versus women. So the aortic valve calcium score more than 2000 is the definition for severe AS. So it's anatomically severe AS, because what we assess here with non-contrast CT is more the anatomic severity of AS. That correlates very well with the hemodynamic severity of AS that we measure by echo. So it's 2000 in men, but it's much lower in women, the criteria for severe AS. It's 1200. And in terms of density, aortic valve calcium density is simply the aortic valve calcium score divided by the cross-sectional area of the aortic annulus. And again, you need to use different cut point in men versus women. So men, the cutoff for aortic valve calcium density is 500, much lower in women, 300. So if we go back to our patient, this is a woman with a calcium score, aortic valve calcium score of 3200. So clearly, by all means, very severe aortic valve calcification. So this patient actually was referred to TAVR and had a good evolution. So it is intriguing. Why do we need to use lower cutoff of aortic valve calcium score and aortic valve calcium density to define severe AS in women versus men? Aortic valve calcium score you can understand because women have a smaller aortic annulus, so certainly you probably need less calcium in women in a smaller annulus to cause the same severity of AS. But aortic valve calcium density, we normalize, we standardize for the size of annulus, and still we have a difference that is important. Well, as you know, and that's what I wanted to illustrate in the title of this editorial. It's very difficult, I would say it's impossible to unveil the mystery of a woman's heart. But still, I think Marie-Annick Clavel was actually a woman and a faculty in our institution with her PhD student, Sertimar. They actually did this very elegant paper in Circulation Research, where actually they found the reason why we have this different cut point to predict severity and outcomes in patients with AS. Actually, women have relatively less aortic valve calcification, but in counterpart, more valvular fibrosis compared to men. So the pathophysiology of the disease is different. The pathophysiology of AS is different. More fibrosis, less calcification in women versus men. And of course, the issue here from a diagnostic standpoint is that the non-contrast CT that we use, it only captures the mineralized tissue, the calcification. It does not see the fibrosis, the non-calcific tissue. So we need to do better here. And we have some very interesting work in progress with our colleague and friend from Edinburgh, the group of Mark Dweck and David Newby, where we, instead of using non-contrast CT here, we use contrast CT. So, with contrast CT, we are able to separate and to measure separately the volume of calcific tissue, which is shown here in white or green, and versus the volume of, we call it fibrotic tissue. Maybe this is a mistake or inaccuracy, because we should say non-calcific tissue. We cannot really confirm it's all fibrous tissue. It can be lipid-rich tissue. It could be amyloid substance as well. So non-calcific tissue is in red. And we can, of course, measure the total fibrocalcific burden, which is the volume of fibrous tissue plus volume of calcific tissue. And you see that the two patients who are actually mid-panel and right are very interesting, because the one in the mid-panel, you see predominantly calcification, so more green, and whereas the one on the right is the opposite. Most of the fibrocalcific burden is related to non-calcific tissue, is a lot of red and very little green. And actually, the patient in the mid panel is a man, whereas the one in the right panel is a woman. But interestingly, these two patients have about the same overall fibrocalcific burden. But in one case, it is more related to calcific tissue. In the other one, it is more related to non-calcific tissue. And both types of tissue actually contribute to the stenosis and to the disease and to the outcome. So we need to have a more comprehensive assessment and not only measure the calcification, but also the non-calcific tissue. So this paper is still not published yet, but it's very interesting to see that the fibrocalcific burden, as you see on the left, is, of course, the volume is much higher in patients with aortic stenosis versus control cohort. And also it increased with the severity of AS. This is logical. What is also interesting, shown on the right panel, is that if you look at the ratio, the fibrocalcific ratio, so that's the volume of fibrous tissue or non-calcific tissue divided by the volume of calcific tissue, it is much higher in women than in men. So again, showing that the pathophysiology of the disease is different. So I think the message here is that we cannot diagnose and treat and manage the aortic stenosis the same way we do in women versus in men. So management of low gradient AS, of course, again, more evidence that there are sex-related differences in the pathophysiology, in the diagnosis, in the management. This recent paper that we did, published in JACC with Ezequiel Guzzetti and Marie-Annick Clavel again, showing that actually the definition of low flow state that we have in the guidelines so far is a unique cut point of stroke volume index lower than 35 ml per meter square, as I previously discussed. But actually what we found is that in this paper, we probably need to use different threshold in men and women again. So in women, the definition would be more 32 to define low flow state, and in men would be 40. And what we found is that especially women with this definition of low flow state have a poor outcome, a much worse outcome following AVR compared to the other groups. The other very interesting paper that we published again in JACC with our friends at the Mass General, Jody Young and Mayo Namasklavang, is this one where actually we show that flow matters in the management of low gradient AS, which makes sense. But here we define flow with the flow rate, the transvalvular flow rate, which is stroke volume divided by ejection time. And interestingly, if the valve area is less than 1 centimeter square and the mean gradient is higher than 40, this is concordant grading, this is severe AS, no problem. If the valve area is less than 1 centimeter square, severe, but the mean gradient is lower than 40, that's the definition for low gradient AS, right? Then look at the flow. And if the mean flow rate is less than 210 ml per second, so this is low flow, low gradient, then the aortic valve area does not necessarily tell you the truth, does not necessarily gives you an accurate estimate of the true severity of the stenosis, because it may be pseudo-severe because of the low flow state. So you need additional tests, dobutamine stress echo, calcium scoring by CT, etc., to confirm the stenosis severity. But if the flow rate is more than 210 ml per second, what we found is that the valve area, which is severe, actually then gives you the right information, and the stenosis is generally severe. And you probably don't need to do additional tests. So in other words, a valve area measured in normal flow condition is reliable. So this algorithm actually summarizes the management of these patients with low gradient AS and discordant gradient. The first very important step is to rule out measurement errors. I think it's extremely important. There are challenges with the measurements of gradient, but valve area, LVOT diameter, etc. The second step is to look at the flow, as we just saw, using the stroke volume index and the cut point eventually adjusted for men and women, 32 and 40, and also the mean flow rate, as we just saw, with this cut point of 210 ml per second. So if flow is normal, this is normal flow low gradient AS, and then severe AS is likely because the valve area is probably right. And then maybe we should consider aortic valve replacement. This situation is not really well addressed in the guidelines. And although, you know, the paper I just showed you suggests that the valve area measured at normal flow is generally telling you the truth, so that the stenosis is likely severe. I like, even in this patient, because I don't like to rely only on one measurement, especially when it is subject to technical pitfalls. It is always good. The patient is symptomatic, as a normal flow gradient AS with a valve area less than 1. It's always good to confirm the stenosis severity with an additional modality such as calcium score, for example. If the flow is low, so stroke volume index lower than 35, mean flow rate lower than 210, this is low flow, low gradient AS with the two categories that we'll be able to differentiate by looking at the LVEF. If the LVEF is reduced, that's a classical low flow, low gradient. The first diagnostic test that you should generally consider is a dobutamine stress echo to confirm the severity of AS and eventually the indication of valve replacement. If in the case that the dobutamine stress echo is not conclusive, which is often the case, I should say, because not all patients have flow reserve, then second test to consider is calcium score. If the LV ejection fraction is preserved, this is the paradoxical low flow, low gradient, as the patient we just saw. And here, definitely the test to consider, the next step is calcium score to confirm the severity of AS. And for these patients with low flow, low gradient, there are more and more studies that suggesting that maybe the least invasive AVR is probably the best, so a transfemoral TAVR would be preferred. So the last topic and controversy is the issue of cardiac amyloidosis in severe AS, and is it the Trojan horse? This is a patient here, again, a patient with paradoxical low flow, low gradient, to make the link with the previous topic. But here, this patient has concomitant cardiac amyloidosis, as we see. So, of course, the people who know echo in the audience will, when you see this type of image, you know, there's sparkling ventricles with biventricular hypertrophy. The atrial septal is thickened. This is very suggestive. This is a red flag for cardiac amyloidosis, and indeed this patient has a severe LV concentric hypertrophy, some RV hypertrophy as well. Impaired longitudinal strain, the mitral S prime is very low, global longitudinal strain is very low. Advanced diastolic dysfunction with increased filling pressure, E of V prime is 24. And so this patient has the confirmation of the cardiac amyloidosis by bone scintigraphy as a grade 3, as you see, score on bone scintigraphy. So this is a transthyretin amyloidosis in this case. And well, the patient at resting echo had the paradoxical low flow, low gradient pattern with a small valve area, low gradient, but LVH fraction that is preserved with low flow state. So this is paradoxical low flow, low gradient. Severity of VS was confirmed here with a calcium score, which was 2300, and the patient is a man, so this is considered as severe AS, and so this patient underwent TAVR. And this is 1 year post TAVR. Well, the TAVR went well, but you see that the LV hypertrophy did not really improve because essentially it is probably in large part determined by amyloidosis. So we had the pleasure and privilege to be invited to do this topic of the week article in JACC last year, actually, about this very, I think, hot topic and an important topic, which is the concomitants of aortic stenosis and cardiac amyloidosis. And I think there are several important messages in this central illustration. I think when we have patients with severe AS considered for intervention, it is very important to look for the red flags of cardiac amyloidosis. So older patients who have an history of, for example, carpal tunnel syndrome is a very important red flag. ECG change like low voltage despite the presence of LV hypertrophy on echo, the pseudo-infarction pattern, that's all things that should, you know, raise suspicion for cardiac amyloidosis. Also at echo, as we just saw, when we have the severe biventricular hypertrophy, this myocardial granular sparkling appearance, and severe longitudinal systolic dysfunction with apical sparing, that's all red flags. And if these red flags are present, our threshold in our institution to do eventually confirmatory tests, so bone scintigraphy, light chain analysis, etc., are very low. And we do when we have red flag, we do bone scintigraphy, we do light chain in the blood, in the urine, to confirm eventually the presence of cardiac amyloidosis. And if you look at the different studies that look at the prevalence of cardiac amyloidosis in patients with severe AS, it is between 10 and 15%. So it's relatively frequent. And of course, if there is cardiac amyloidosis, probably we should address this condition medically with transthyretin cardiac amyloidosis. There are some stabilizers such as tafamidis, etc. With light chain, well, we should consider chemotherapy. And for the management of AS, it is important to confirm the stenosis severity. Often calcium score is the best approach to do that, because dobutamine stress echo in these patients, they generally do not respond well, and you don't have any clear answer regarding the severity of AS. So calcium score is probably the way to go. And although initially there was some report that maybe, you know, AVR would be futile in these patients with aortic stenosis and cardiac amyloidosis, there is more and more studies, and there will be one published in JACC this week, showing that actually these patients have with AS, they have relatively good outcomes following TAVR, and almost as good as those with no cardiac amyloidosis. So presence of cardiac amyloidosis should not preclude the consideration for AVR. We should treat the aortic stenosis, because the severe AS that is left untreated is deadly. But at the same time, we should also treat the cardiac amyloidosis, and we have options nowadays to treat cardiac amyloidosis. So I will end here. This is my team. And that's really those who are really doing the hard work. And as you see, there is a predominance of women in my lab, and people often ask why. Why? There are three reasons. The first is that women have still longer life expectancy than men, so it's a better investment for my lab. Second, they are able to do multitasking, which men we are not as good at. And finally, they have a very interesting disease phenotype with aortic stenosis to study. So I will end with this famous quote of Benjamin Franklin, who said, by failing to prepare, you are preparing to fail. I think it applies very well to politics, of course, but also to medicine. And I thank you very much for your attention.
Thank you. Questions or comments from the audience?
Dr. Pibarot, that was great. We're late. I just wanted you to comment on the age. You know, we're talking about patients 80 and older. I think 3 of the 4 examples you gave were 80 and older. And taking them to either surgical or even TAVR is not without risk, as well as taking into account the cognitive dysfunction that can occur and pacemaker requirement. So can you comment on, you know, and if you use AVR as an endpoint, that's a self-fulfilling prophecy because that will vary. And once they achieve that, that's different than, you know, actual mortality. So I guess 2 questions. One, again, this is an elderly population that you're sending to an intervention, which may have an impact on their cognitive function and subsequent quality of life. As well as looking at, you know, mortality as a firmer endpoint, because in some of the trials you were talking about quality of life, you were talking about hospitalizations for heart failure, which are certainly softer endpoints, but for doing the major intervention than just looking at mortality.
Oh, I totally agree. I think, you know, we are, with aortic stenosis, we're dealing with older patients, vast majority of the case. And in these patients, well, of course, longevity of life is important, and we want to prolong the life, but the quality of life and cognitive function are as important, even more important. And I you know, most of the trials that have been done, I've used more like what we call hard endpoints. Are they the best endpoints? I don't think so. You know, mostly like, for example, the partner trial, we used mortality, stroke, and then eventually hospitalization. The improvement in functional class and quality of life and 6-minute walk test is not necessarily included in the primary endpoint. It is included in the secondary endpoints, and we've seen some spectacular improvement in quality of life as well. Even surprisingly, you know, in the elderly population. So I should say I've been surprised by the results, you know, for example, in the partner 2, the partner 3 trial. The partner 1, you know, the patients were so sick and so short life expectancy, it's difficult to derive really good conclusions. But in the subsequent trial, we've seen some very important improvement in, for example, in the KCCQ scale. So there are some improvements, not in all patients. And I think the challenge after doing this trial, you know, like validating, if you will, the utility and indication of TAVR versus SAVR, the next step is probably more to identify now, to develop tools to identify the patients who will not benefit of any AVR, you know, TAVR or SAVR. And this exercise, this work still needs to be done. We have not yet tools to identify patients in whom the treatment will be futile. And I think that we should not look at only mortality, as you very well said, but we should look at futility versus utility and integrate mortality, yes, but also improvement in quality of life. And we need to develop tools to identify, before AVR, of course, patients who are very unlikely to have any improvement in longevity or quality of life. So the patients in whom the treatment will be futile. We have some clues a little bit, but it's like we know that patients who have severe frailty, which is not captured in the STS score or Euroscore, well, these patients, they often have a futile AVR, unfortunately. So this is one component, but I think frailty is one thing, but we should do more and go beyond that.
Yes, thank you. I think the key thing is to individualize and personalize, the treatment based upon the patient in front of you, which is very important.
Yeah, I agree. I think, and that's a bit also the idea of the cardiac damage staging, but I think the staging should be more than cardiac, should be systemic staging. And in order to individualize not only the timing of intervention, but also the type of intervention. We need to do personalized medicine in AS, and we need to better this field.
Yes, thank you very much. This has really been a great talk. Thank you very much.
Thank you.
Bye, Philippe. Bye. Thank you.
Thank you very much.
Philippe, thank you so much for being here. I look so forward to working with you on the SMART study. And thank you for your contribution. And of course, your incredible presentation and brilliance came right through, covering soup to nuts on aortic stenosis. Thank you so much.
Thank you so much, Roxana. Look forward to working with you.
Merci beaucoup.
Merci.
Au revoir.
Au
Bye,
revoir.
Philippe. Bye.
Thank you. Bye. Take care.
Bye-bye. Bye-bye.